I think there's one topic that got more media coverage in the past year, and that's the H1N1 pandemic. And we are very, very pleased to have Dr. Ken Scott, the Director of the Pandemic Preparedness Division, Public Health Agency of Canada, to speak to us. He was on the front lines and basically where the pavement hit the road as co-chair of the Clinical Care and Antiviral Task Group, developing recommendations for management of the pandemic. And because of his very important role, he's well versed in the next topic, H1N1 lessons learned. So I'd like you to welcome, please, Dr. Ken Scott.
I'll try and keep you on time. Actually, the number one topic of interest to Canadians last year was the economy. H1N1 was number 2. I'm an infectious diseases specialist, so I'm going to give you a talk from the perspective of somebody who's practiced infectious diseases. I will say, however, I've given many talks to many meetings over the years, and at the beginning we have to disclose if we have any disclosures. I do have a disclosure, and I will relate my disclosure in the form of a story. In January 2010, The Economist published a special feature on the first 10 years of the 21st century and what life was like and how it had changed. I don't know if any of you read The Economist or if you read that article. But in that article, they said, or they quoted the most dreaded word in the English language, attributed to Ronald Reagan. The most dreaded word in the English language is, or was, sentence rather, most dreaded sentence, I'm from the government, I'm here to help. So I'm gonna tell you about what I know about H1N1. I will tell you that I'm a substitute, a pinch hitter. I first saw this presentation late on Wednesday. If you like what I'm going to say, I will take full credit. If you don't like anything that's happening here, it's not my fault. Now, because I didn't actually prepare this talk, I will talk a bit off the top of my head, what little I've got left, about how I view H1N1. I look at this from an historical perspective. Most people know or remember the Spanish flu, 1918. That was an avian virus that crossed into humans and propagated itself quite well and killed millions. That was an H1N1 virus. Hemagglutinin is the H1, neuraminidase the N. So the hemagglutinin is involved with viral attachment, the neuraminidase involved with the viral release from already infected cells. H1N1. H1N1 was virtually the only influenza virus this world saw until 1957. 1957, Asian flu started. Interestingly enough, in Asia, in February. It was H2N2. What happened to H1N1? Vanished off the face of the earth. No more H1N1. It had been evolving and drifting since first introduced into humans in 1918, but vanished, never to be seen, until 1977. See, in our cleverness, humans like to keep things. My mother-in-law is a hoarder, but you see, they keep things. We kept things in a lab. 1977, that original H1N1 strain that had entered humans in 1918 escaped from the lab, and I'm happy to tell you that caused subsequent problems in humans. So that back in 2008, 2009, that year, the influenza virus that caused most illnesses in Canada was H1N1, seasonal H1N1, one of those grandchildren, if you like, of the laboratory escape from 1977, the Great Escape. In 1968, H3N2 arrived, Hong Kong flu, and took over as the dominant virus in this world, replacing most of the H1N1 strains because we'd already released it again, and the H2N2. So H3N2 became a dominant strain. Now, we've been waiting for a number of years for another influenza virus to arrive. In fact, our plans have been in the development for many, many years. We were expecting H5N1 from the Far East. So we were very clever, and we were surprised. So I'm going to quickly go through some of these slides because I say this is not my talk, and I like talking about off the top of my head. So I'm going to tell you what happened during the pandemic, focus a bit on pregnant women, but I will, just since this is about pregnant women, and I've seen pregnant women, I participate in WHO conferences, teleconferences, and meetings, workshops that I've gone to in the WHO. I do disclose that I work for the government, and therefore I'm probably biased. But I participated in a teleconference back on the 18th of August, and on that teleconference, Brazil was sharing with us their experiences with their first wave. And of course, in August, that's the middle of their flu season. Their flu season is normally in the southern hemisphere is from May to October. So they were right in the thick of things. And what they had found was that they had, at that time, 1,058 cases of influenza. And in pregnant women, they had 667 pregnant women, which was 25% of all the females in Brazil who were documented to have H1N1 were pregnant. So 25% of the patients they were seeing in the hospitals, hospitalized women, were pregnant. Now, it might be that in Brazil, it's sort of a younger country than we are. Maybe 25% of the women in Brazil walking around are pregnant. But no. In fact, it was 1.9% of the Brazilian population is pregnant at any one point in time. So, in fact, a disproportionate number of pregnant women back then, and interestingly enough, a disproportionate mortality rate, and in particular, deaths by trimester. They had 9.1% in the first trimester of their death died, 27.3 were in their second trimester, and 54.5 were in their third trimester. And on that call, my Brazilian colleague was very excited because the women were deteriorating quite quickly. They were being sectioned in the emergency department before even making it to the ICU, or being sectioned in the ICU. And it didn't really seem to make much of a difference in terms of their viral pneumonitis. The intervention, the sectioning to try and save the baby didn't, in most cases, save the mother. So they went on to die anyway. So it seemed to me back then, and I think we've already heard today, that H1N1 in pregnancy is bad. The other interesting thing, though, is in the children that were delivered in Brazil, so this is a story, but what they had noted is they did not separate the babies from the mothers who were hospitalized with H1N1. They did not separate the babies. They didn't implement any particular infectious precautions. They did not put the babies on oseltamivir. And none of their babies at that particular point in time came down with pandemic influenza. So what can I say from that? Well, one, so pregnancy influenza or pandemic influenza H1N1 bad. Two, most of the babies born to these pregnant women who were hospitalized and unwell did not in fact themselves have H1N1, so that's good. The other anecdote that he gave was they were having problems in Brazil in particular, and Mexico gave the same anecdote, but in Brazil, antivirals were very, very closely controlled by the government and not released, were not particularly available. And when the people started dying, they made the antivirals available in fire departments. So you could go to your local fire department and pick up your oseltamivir. And my Brazilian colleague said that seemed to make a big difference. That's a story. It's a very, very acute, short wave, so probably coincidental. But there is evidence now that early institution of antiviral therapy does make a difference in prognosis, and we have Canadian data to support that. So H1N1 pregnancy, bad. The babies seem to do okay. Early antiviral therapy, good. Is that sort of the end of the? No. I'll actually see what this is Dr. Grandin's talk. I don't take any responsibility for it. So I work for the federal government, and we've already had one of my colleagues up here. The federal government, we do things like assist with the preparation of guidance documents and the regulatory process. We put into place some regulatory changes so that infant or children under the age of 1 could access oseltamivir, which is not normally, that's not normally recommended. The important thing that you need to remember is, as a federal government employee, we make recommendations and things. It's the provinces and the territories that deliver. So that if you have any concerns about how this pandemic happened, it was the province's fault, not ours. So we did have a plan, and that's been around. The most recent iteration of that was in 2006. It's based on 7 pillars, which is surveillance, drugs, which I like, vaccines, which I like even more, public health measures, clinical care, communications, and research. This particular plan is huge. You can go onto our website and read it. It was published, the most recent iteration, in 2006. The division of which I'm director was responsible during the pandemic, actually, believe it or not, that fiscal year, to conduct a tabletop exercise to inform a new version of the pandemic plan. So we were very grateful that the pandemic came and saved us the trouble of doing this exercise, because we don't like to organize things like that. So we've learned, and we thought this was unbelievably good timing. So the first Canadian case, as you know, was back in April. We don't really believe that instituting border controls actually will make much of a difference in terms of acquiring the virus in any particular country. The pandemic response has lasted 10 months. We've had just over 8,000 cases. We've had 1,400 in the ICU, and we've had 428 deaths. There have been 2 deaths this year, so not much around. What did we see in Canada in H1N1? We saw pregnant women in their 2nd and 3rd trimester, and that seems odd because that's what everybody else is finding too, including those Brazilians. Children under 5 were at risk, especially those under the age of 2. And remember, we can't vaccinate children that are less than 6 months of age. All right, so how are we going to protect those young 6-month-olds? Perhaps through vaccination. People with underlying medical conditions, severely obese, and people living in remote and isolated areas. Now, why pregnant women are at risk, I don't really know. It may be because of altered immune status, so that they can carry their child. It may be like the morbidly obese people, that with that weight, particularly in their 2nd and 3rd trimester that they're carrying around, the lung excursion is very poor, and that may predispose them to viral pneumonitis. This particular virus has receptors, some of the strains, for sialic acid receptors in deep lung tissue. So perhaps it's just the decreased lung excursion. This is our wave, if you like. You can see that it sort of peaked in late October, early November. We actually rolled out the Minister of Health announced the vaccine was available on the 21st. Some jurisdictions started vaccinating on the 22nd of October. The center of the universe, Ontario, started vaccinating on the 26th. So we were introducing a vaccine right at the peak of the pandemic, and it takes about 2 weeks for a vaccine to take effect. The first wave, we had high rates of illness and patients in the ICU on ventilation, and high vulnerability amongst our Aboriginal people and pregnant women, and that was the case in Mexico as well. So our first experience with this virus, we were not very happy about it. I was an ICU specialist for 7 years, and I still actually talk to my ICU colleagues, and I speak ICU. The intensivists were very worried. We organized a meeting back in September at the insistence of the Canadian Critical Care Network to plan for this virus, because they were actually quite worried. The second wave came. The median age and proportion of people who contracted H1N1 with underlying conditions was higher. So the second wave, more people had underlying conditions. There was a lower proportion of cases amongst people of Aboriginal origin and pregnant women. Lower. Overall, though, as you saw from that peak, hospitalizations were 5 times higher, deaths were 5 times higher, and ICU admissions were 4 times higher than with the first wave. And the first provinces that were hit with our first wave, as you may remember, was Manitoba, with some remote and isolated and Aboriginal communities there. Influenza is a patchy disease. It can affect, if you live in Ottawa, which is the center of Canada's universe, you could have an outbreak in Nepean and not have one in Canada. It's a patchy disease. Canada put into place various interventions, and I'm happy to say that the Society of Obstetrics and Gynecology was very helpful, very aggressive, putting posters and things in their waiting rooms and in their examining rooms, encouraging vaccination. We were encouraging, because they were an at-risk group, the pregnant women receive oseltamivir with influenza-like illness symptoms, not waiting for any confirmation with a laboratory test. So a top priority group for immunization. Now it says here, these aren't my slides, that we had a 34% vaccination rate amongst pregnant women, which is true, which is higher than the normal. What would you guess is the normal vaccination rate amongst pregnant women? And they are a risk group, and normally it's recommended that they be vaccinated. Seasonal flu. What would you think? What is it? It's in the low 30s normally in most jurisdictions. Yeah, so as far as I'm concerned, with the confidence intervals and the data, this is probably the same, which is very interesting. So vaccine uptake was not particularly very good, despite aggressive campaigns that were conducted in our country and by the Society of Obstetrics and Gynecology. So they were aggressively trying to encourage vaccination. One of the worst groups to receive vaccinations throughout the world actually were healthcare workers. They're particularly non-compliant with vaccinations. So that, so 34% vaccination rate, we were hoping it would be more like 100%. And vaccinations will protect the fetus. Some of that data goes back to Bangladesh studies published in the New England Journal in 2008. So vaccinating will protect the newborn for the first 6 months until such time as a newborn can be vaccinated. And there have been studies looking at not only antibody titers, but also on real-world resistance to seasonal influenza, at least. So pregnant women, our initial vaccine, as per the WHO, was non-adjuvanted. Non-adjuvanted. Most Canadians here, how many here got vaccinated? Okay, that's great. I practiced infectious diseases, including with immunocompromised. I ran HIV/AIDS clinics for years. I used to always get 2 seasonal influenza vaccines every year. Seasonal influenza vaccine, not particularly very good. So on average, maybe 60% efficacy rate. So because I was managing HIV/AIDS patients, I wanted to make sure that I was protected and would not constitute a risk to my patients. So I would get a vaccine as soon as they came out, and I got another vaccine in January all the time. An adjuvanted product, the adjuvant we used was, not we, the company, GSK, was squalene. How many of you have ever been exposed to squalene? None of the rest of you? Squalene is made in all human cells. In fact, everybody here exudes tons of squalene. If I were to do a swab, your sebum contains tons and tons of squalene. It's a necessary chemical in cholesterol synthesis, found in particularly high concentrations in the liver. So in fact, I believe many of you probably did see squalene. But anyways, we had a squalene-based adjuvant with vitamin E, tocopherol, and those oil and water-based adjuvant vaccines have been around since 1930s. And they've been extensively used, adjuvanted products, in Europe with squalene adjuvanted products since 1997. We don't use influenza vaccines in our country, normally are non-adjuvanted. What we did find by using an adjuvanted product was that our antibody titers that we produced were extremely high, much higher than we would have ever expected with a non-adjuvanted product. It could be confounded by the fact that we were using a monovalent vaccine, not a trivalent seasonal. So not 3 antigens, just 1, but very, very high antibody titers. We wanted high antibody titers because we were worried about antigenic drift of the virus. So we wanted to be able to protect Canadians against this virus drifting, mutating, and that is usually done by having a more robust immune response. So the adjuvanted product, robust immune response. The WHO initially suggested with pregnant women, from this talk you've heard earlier, we don't like using drugs or vaccines in pregnant women. And so we have a lot of experience with non-adjuvanted product, and without a lot of safety data on using an adjuvanted product, the initial recommendation was unadjuvanted vaccine in pregnant women. And a precautionary measure, particularly for those under the age of 20 weeks. The WHO changed their recommendations, I think it was around November, December, to say that we could start using adjuvanted products, that the data they had available suggested that they were equally efficacious. In Canada, we said try to use a non-adjuvanted. If you had the adjuvanted, use it. And I do know that many pregnant women in Canada did, in fact, take the adjuvanted vaccine. 100,000 pregnant women so far that we're aware of. Drugs, I like drugs. I've already told you that pregnant women were a risk group, and with an H1N1-like illness, implementation of drug therapy as soon as possible was a recommendation. Some obstetricians and gynecologists wrote prescriptions for their patients. I know pregnant ladies, and left them they had them at home, and when they developed their symptoms, they would just fill their prescription with their local pharmacist. Pregnant women statistics, as of the 6th of March, we had 1,299 hospitalized women between the ages of 15 and 44, so 20% were pregnant. And again, I don't think 20% of women in that age group are pregnant. 61% in their third trimester. 4 pregnant cases resulted in death. All of those were in the first wave. We've had no deaths in pregnant women in the second wave. Most frequently, underlying medical conditions were chronic pulmonary disease, diabetes, and immunosuppression, including cancer. And the vast majority of babies born to mothers with documented H1N1 infection have not themselves become unwell, which is again the experience in the world. We thought it would start in Asia. We were wrong, dead wrong. Seasonal influenza, we didn't know what would happen when the pandemic started, and we were prepared for another potential seasonal. We didn't know if it was going to be seasonal or if it was going to be H1N1, and we didn't know if we dealt with H1N1, if seasonal would come in January or February. Historically, at least, though, when new pandemics have arisen, the pandemic strain has been the dominant strain for many years, at least 2 to 3 years. And for those of you who morbidly follow history, and to know that the Greeks described what we now think are pandemic influenza episodes back in their days, the shortest interval between possible pandemics, even going back to as far as the Greeks, was about 8 years. So with any luck, we have 8 years before we face another potential pandemic. Healthcare workers, I don't want to talk about that because I want to answer questions. These are about the previous pandemics. And it's hard to say, you know, things really changed between the first wave and the second wave. And what were the changes? Different population groups. Manitoba, for example, was really hit hard in the first wave and had very little illness in the second wave. Prince Edward Island, I think, throughout the pandemic has had no deaths for whatever reason. I guess it's the lobsters there or something. I don't know. But you know, it's very interesting how things have changed. What were the effects of some of the public health measures that people adopted? Sort of coughing into your sleeve, washing your hands. We do know that people were washing their hands. So outbreaks of C. difficile, which I like, but outbreaks of C. difficile in Quebec were dramatically less during the second wave of the pandemic because people were actually sort of washing their hands. So we do have evidence from other illnesses, other infectious diseases, not just C. difficile, that people were washing their hands. They were practicing social distancing. If they became unwell, they were staying home. So they were actually listening, for the most part, to advice from public health officials. So what was the effect of all of those interventions versus the antivirals that we had? And we had lots of antivirals, both in a national antiviral stockpile, which is a federal, provincial, territorial stockpile, and our national emergency stockpile. We used 7% of the virals in our national antiviral stockpile. 7% only, not very many. North America was hit first and the hardest. Our response was a collaboration across sectors and governments. This, again, is not my slide. It's not the largest mass immunization clinic in history. My mother is Norwegian. The Swedes vaccinated 6% of the people. Norwegians, I think, 56%. And Canadians, when all is said and done, I think will be around 40%. Immunization rates were higher in children. Early antiviral therapy was particularly effective. But the interesting thing is, if you've ever practiced infectious diseases in a hospital and somebody has pneumonia, they order the antibiotic stat. And normally the standard is that you would get antibiotics flowing in your vein within 60 minutes. The average time from ordering an antiviral to having an antiviral available to you, and this is oral, was about 4 hours. So that's quite interesting. The other interesting thing I found during the first wave, when people were being admitted with community-acquired pneumonia, when we knew that this influenza presented with a viral pneumonitis, people were being treated with antibiotics for their community-acquired pneumonia, but not antivirals. Like only about 60% got antivirals initially. So that seemed very strange to me. So, importance of practicing and testing your plans, and we've been gathering lots of information. Many people have certainly been providing us with their perspectives as to how the pandemic unfolded, and we've also been sharing our experiences with our allies around the world. And based on the information that we've been gathering, and I already told you it was the expectation that our Canadian Pandemic Influenza Plan, which is a joint federal, provincial, territorial plan, will be changed to reflect what we've seen during this most recent pandemic. We still need greater clarity on various roles and responsibilities. Information sharing can improve, we think. The timeliness of guidance for healthcare professionals. Even I co-chaired as you've heard, the Clinical Care Antiviral Task Group, which consisted of virologists, PharmDs, pediatric infectious diseases, adult ID like myself, Society of Obstetrics and Gynecology, pediatricians, various professionals. It took a long time to get various guidelines out, and who should be responsible for the development of these guidelines? It seemed that everybody was looking to the Public Health Agency or the federal government to be the lead. As public health, we provide advice based on populations, not to specific patients. And yet it was the expectation. I can remember at Christmas being backed into the corner at the various festivities that I went to by family physicians who found out that I was the director, and I was the emergency operations chief at our emergency operations center, saying you have to do better, you have to provide us with guidance. So there seems some confusion out there as to who should be responsible for the development of these guidelines. It may be that we can facilitate professional organizations, like we did with Canadian Critical Care Society, to develop guidelines, post them on their website, and link from ours. Vaccine administration, you know, in late summer, early September, if you look at the number of people who indicated in various surveys that they were going to be taking the vaccine versus the number, say, around November, December, what do you think happened to the numbers who said they were going to take the vaccine based on our aggressive campaign? Dropped. Absolutely. Absolutely. And in the United States, nothing to do with pandemic influenza, but last month they published in their, the CDC published their results on vaccine uptake for vaccine-preventable diseases in the States. And what do you think it's doing? Dramatically falling. Yeah, so it's falling. So we don't seem to be winning the battle here. And the Institute of Medicine in 2009 published their report on vaccines, and it said it's not sufficient to tell the population that the vaccines are safe. You actually have to deal with the fears. And they felt that the governments, at least the CDC, felt that the governments were not adequately dealing with some of the mythology that exists around vaccines. Unless it's specifically addressed, unfortunately, this was the first pandemic in the age of the internet. And as somebody who had to sign off on a bazillion, 0.2 webmails, it's unbelievable what people will believe out there. And so the conspiracy theorists are winning. If you Google flat Earth, there's 1.8 million hits, but unfortunately a lot of people Google H1N1 and they find all kinds of nonsense out there. And a lot of it's about vaccines. And we have to do a better job of communicating the risks and the benefits of vaccination. And we could do a better job on surveillance. What that means is I would like us to have the capability of rapidly rolling out projects so that we could know exactly how many people and what risk groups were acquiring infections, so that I would like to have 5 pre-approved research projects on a national basis, one of them surveillance, that I could roll out, previous ethics board approval, previous investigators identified, methodology there, funding in place, and when the next pandemic hits, and I really hope it hits before 8 more years because I'll be too old, so hopefully it'll be sooner than that, just roll these things out and we could learn information which could inform our response better. So I really normally like answering questions. This is not my talk. If you didn't like it, it's Dr. Grandin's. Okay, Dr. Grandin, Grondin. But if you have any questions, I would be happy to answer them. Yes?
It's not really a question, it's just I'd like to give you some information that I'm from Mother Risk, you've probably already figured it out. I'm not sure if you looked at the posters in the meeting, but my colleague here presented a poster on our surveillance that we did at Mother Risk, and you'd be happy to know that after calling Mother Risk, 85% of all our pregnant women took the vaccination. But interestingly enough, this was a study where we just wanted to know if they had it or if they hadn't, but also we wanted to know the determinants of the decision-making behind why they decided whether or not to use it. And it was interesting, we asked them about the seasonal flu vaccination and what they would do if they weren't pregnant. And it's interesting, the ones that they said that only if they weren't pregnant, only 25% would take it. Do you know what I'm saying? If it was, and a lot of, we asked them questions about the information they received. Now, this is something really important. Oh, the Health Canada lady's gone away. Oh, sorry. I know, I'm sorry I talk way too much, but you picked 2 topics that I'm really so involved with this past year. Well, I'm always involved with the antidepressants, but the H1. And a lot of it was how the message came across. And we'll be looking forward. Obviously, we don't have, it's not published. We haven't actually finished writing it up. But my colleague, Sachi Saguchi, she actually did a poster, I don't know if you saw it. But I'd really be interested. But anyway, we're very proud to know that we did increase it to 85%.
Yeah,
so
that's great.
And I also just wanted to ask you a question. You'd had a lot of statistics on there, and we've been writing the background for the paper, and I assume none of them are published in the peer-reviewed literature because we looked it up. Did you find anything, Sachi? We couldn't really find any Canadian statistics, so I was wondering where all these numbers came from.
There's quite a lot of information, actually. It's been published in things like the Canadian Medical Association Journal on our experience with H1N1. If you go to our website, Influenza, there's a Flu Watch section where they've been publishing the various information. That's also that's also available there. So it's actually it's not published. It has been published in journals like the Canadian Medical Association Journal. There's several articles on Canada's experience with H1N1.
No, I'm talking about the pregnant, specifically the pregnant ones.
There is information in there about the higher risk that pregnant women experienced during this particular pandemic. There is information on, as a percentage, how many were hospitalized. There is information that if they were started their antivirals earlier, like anybody else, that they did better than if their antivirals were started later. There is information on the trimesters.
Oh, okay. That maybe we didn't really look that closely. But anyway, thank you very much.
Yes, thank you. And the other thing, this week in PLOS ONE Medicine, which is an online journal that you can access, there is an article there by mathematical modelers, and they look at what persuaded people to actually listen to advice. And if people in particular had contact with public health, so that was a factor in people actually doing things. If they actually had contact with their family physician, that seemed to increase their compliance with things like vaccination. And the third factor was if their place of employment offered a vaccine program and encouraged vaccination, that was also a factor. So public health, healthcare providers, and employers seemed to influence people's decisions with respect to whether they were going to choose to be vaccinated or not.
That's really interesting. I'm going to be looking for that because the comment and the question that I had was really related to the uptake And one of we got a lot of questions ourselves, being the regulator, about the vaccine and things like this. The crazy stuff on the internet was brought to our attention. I had a friend call me and said, you know, there's a video on YouTube of a guy who can now only walk backwards thanks to the vaccine. Oh, you know this, eh? Oh, it's not like I couldn't dream that one up, you know. But one of the things that struck me was in Ottawa when the rollout happened. One thing that really twigged me was, because I have a pediatric background, was a dad who called into a call-in show and said, like, I don't know why my kid who has ALL and is immunosuppressed can't get his vaccine at his oncology clinic. But that got me thinking about uptake and the stakeholders that we've had involved in our consultations. People who have a chronic disease and have a good relationship with the medical system are much more trusting of the system. And is there a way to use, it would be interesting to know about the uptake, the numbers that you showed, how many of those people actually were willing to accept the vaccine because of their previous medical history, and if that made a difference.
People with chronic underlying medical conditions, something like 89% of them accepted the vaccine. So we actually have all that information in bar graph form. But would people who, because there's scientific, there's statistical evidence, and there's anecdotal evidence. And one of the things that's really struck me working in the regulatory environment is how critical that is for people. So if you had people who have chronic diseases going out and saying, I'm getting the vaccine and this is why, would that affect other behavior? It's a question that I have. I don't have the answer to it. But yeah, clearly we have to do something better. We have to be able to address the fears that are out there, and we have to be able to live in the age of the Twitter and the internet. The adverse effect that most people feared was Guillain-Barré syndrome. Now, we put in place the most robust vaccine surveillance system we've ever put in place, ever. And it was active from children up through into and including adults. And based on historical data, the historical data for Guillain-Barré with influenza vaccines, for example, is about 1 in a million. With our most robust, in that data, we weren't looking for it as closely as we are now. So with this particular vaccine, the GBS rate was about 1 in a million, about 1 in a million. So we were looking for it more closely. We found about the same rate. So I think if we looked more closely previously, we might have even found higher rates. The other thing is infections cause Guillain-Barré. Classical is Campylobacter. If you have influenza infection itself, 4 to 7 per 100,000 patients with influenza infection will get Guillain-Barré. So if you're worried about Guillain-Barré, get vaccinated.
I just have a comment to go on all that. Age of Twitter, age of Facebook, and the internet I think is really key in here. That uptake information on the pregnant women really shows that it's just people who've already decided the vaccinations are a good thing that are getting vaccinated. And there's a lot of good talk about data and looking at determinants of what make people do things, and I think this kind of data-driven policy is really good, but I think you also have to consider fighting fire with fire a little bit, just as throwing it to you because you're in the public health agency, but you're fighting against like Tom Cruise and Jenny McCarthy telling North America what's good or what's bad for them. So we may have to sort of expand, like get some of our higher profile individuals to like maybe grab David Suzuki to get a little cabal of high-profile Canadians and have them sit in a room with all the experts and do something about giving people a trusted voice, because they don't trust doctors and they don't trust anybody who's ever been within spitting distance of a pharmaceutical company, which is just the reality. So all of us in the room know how complicated it is and that there's real people involved in all these decision makings, and it's not a massive conspiracy. I myself had to write several emails to friends and families through the H1 vaccination claim, with very detailed telling them why it's a very good idea. But people with chronic diseases, for example, I think that's a really key thing, because people always think of themselves and that there's this conspiracy that they just want to sell vaccine, but they don't think that when they don't vaccinate themselves, that kid in the oncology ward might actually get infected because the population wasn't protected against the infection. So bringing up that measure of social responsibility, not just protecting yourself, but protecting those most vulnerable, which is sort of something I personally use when I'm speaking to friends, because we all have lots of friends, and some of them think that vaccines are a bad thing, and I ultimately say, well, there may be a small increased risk for an adverse event, which there is for any drug, but I'm going to take that risk so that somebody else's kid doesn't get polio or whatever, MMR or whatnot. So I'm from the experience here, it's really it seems that the messaging, I know that we had problems with the dissemination of the vaccine and everything, but people really didn't buy it as much as we needed them to, and we almost need a marketing spin to this from our public health standpoint.
Yeah, we're going to have to change, as I said, our approach, in particular, to deal with the various fears around vaccination. People don't trust authority figures. They don't trust union stewards. If you're in the union, if you're in the church, you don't trust the priests. And the number one group, even in Canada, in Leger polling, that people do not trust, not as bad as in the United States, the number one group they do not trust is the government. 25% of people who attend X-Files conventions believe that they're based on true stories. So that just shows you that we've got a lot of problems to work with. Thank you for your attention. I know I have to leave right now. I am from the agency. We're the Men in Black. Thank you.
We trust you, Dr. Scott.